consultant endocrinologist and assistant professor for endocrinology at Bakai Medical University, Karachi. This symposium is sponsored by Hilton Pharma. The title of this talk is Combination Therapy, a cornerstone for cardiovascular risk reduction. Let me introduce our speaker, our panelist. Our first panelist is Professor Bilal Zakaria Khan. He is consultant interventional cardiologist, former professor and executive director of Punjab Institute of Cardiology, Lahore. So please join us on the stage. Second panelist is Professor Qazi Abdul Samad. He is also consultant interventional cardiologist and HOD Sheikh Zayed Hospital, Lahore. The speaker of this session is Professor Peter Jan Lansberg. Dr. Lansberg is a lipidologist and senior clinical staff member, Department of Pediatrics in Molecular Genetics, University of Groningen, Netherlands. Please, sir, join us. Thank you.
Okay, ladies and gentlemen, I'm ready for the presentation and very pleased to be back in Pakistan, and I'm in a very esteemed group of physicians here, and I can see there's a big audience. Most of you are endocrinologists, so I'll try to fabricate my presentation that it's more addressing some of the issues that endocrinologists are facing, and I think diabetes and metabolic syndrome are, of course, first and foremost. These are my disclosures. The main topics I would like to address and maybe also discuss with you is why LDL cholesterol is really an ultimate target, not only for your cardiology colleagues, but also for the ones that are taking care of patients with diabetes or with renal disease, or sometimes also familial hypercholesterolemia. I think that's also a disease that is usually seen by the endocrinologist. I think everybody is familiar with the meme, the lower is better, and that's something that we've learned over the last 30 to 40 years, where we've seen shifting targets going from 150 to 120 to 100 to 70 to 55 to 40. Another meme is the longer the better, so emphasizing that this is a lifelong treatment in patients of high risk. And the new meme I would like to introduce today is the earlier the better, in primary prevention and in secondary prevention. Then I'll show you some data why I am convinced that statin and ezetimibe is really like a marriage made in heaven. It is a very proper and effective combination, very safe. And last but not least, I'll show you what is being incorporated in the guidelines regarding lipid management and also risk factor management. So let's start with the introduction. This is the good news, and this is good news in terms for the way we are able to manage patients who suffer a myocardial infarction. In the 60s and 70s, if you had an MI and you reached the hospital in time that you were alive, your chances of coming out alive were still pretty dim, roughly 50%. Half of the patients who came to the hospital alive didn't come out of the hospital alive. So that was a huge impact. And you can see very nicely depicted on this slide all kinds of new interventions, devices, drugs, CCU, that helped to rapidly reduce that incidence of mortality in patients after an MI to 5 to 10%. So in other words, now 90 to 95% of the patients leave the hospital alive. That doesn't mean that they're completely healthy and happy again. There are still, of course, comorbidities associated and also damage to the heart that deserve treatment, but at least they have survived. Despite the good news, you would expect that cardiovascular disease in general would have gone down as well. If we are so successful in treating the acute problem, why are we not successful in treating the incidence of cardiovascular disease? Because as you see in this slide from the World Heart Federation, there is a 60% surge of cardiovascular mortality over the last 30 years. So it's not a time to be complacent it's a time that we have to be really aware that this is not going to decrease in the next 10 years, it's going to increase unless we change some of our efforts to manage these patients. Now, why is this a real big problem? This is a picture from Brighton Beach in the UK in 1978. And I dare you to find one obese person on this picture. There is one really far in the back, I found one. But as you can see, everybody has a normal BMI. Now, they also made a picture in 2018, and now my question is, who is slim in this person? And again, it's difficult to see. So the situation with obesity is rapidly increasing, and there are areas where there is a huge increase, US, in obesity prevalence. Now, how do we improve the way that we protect patients from cardiovascular disease? And I think these are what I call the 3 pillars. It's sort of a meta view of how I think medicine could properly and very effectively work, the 3 pillars that help us to improve clinical care. Science shows us what we could do. And science, of course, has been an integral part of medicine since its conception in the late part of the 1800s with Virchow. That is what evidence-based medicine more or less started. And it's continuing to grow and to grow and to grow. The amount of science that's being published on a daily basis is astronomical. I focus on a special newsletter where I look for publications on statins. And every week there are at least 60, 70 publications just on statins. So I'm not even talking about a broader spectrum of lipids, no, just on statins. That means that the amount of data, the amount of science that we have to digest is far beyond our capacity. Our hard drive here is not big enough to deal with all that information. So what we need is to interpret the relevant science and translate that into practical, applicable guidelines. And guidelines explain to us what we should do in our patients. So science fuels the guidelines, and then it helps us that we see a standard patient that we know, okay, this is a patient who has cardiovascular disease, we're talking about lipids, these are the drugs that are proven to be effective and safe, and these are the targets. Now we come to the big culprit. The guidelines are not always implemented and practiced. I'll give you an example of a paper that I read some years ago where they asked cardiologists and family doctors, how well do you know the guidelines? And they all said, we know the guidelines very well. Do you know the targets? Yes, of course we know the targets. Exactly. And the last question was, how well are your patients treated to target? And they said, well, I think we're doing a pretty good job. It's probably 70, 80% of our patients that need to be treated with lipids are on target. However, there was electronic health records from these doctors, so they could evaluate what they did in real life. And I think you can already guess what they found. It was not 70 or 80%. It was not 60%. It was not 50, 40. It was roughly 20%. So that means, although we know what we have to do, we don't do what we need to do. And the only way to make sure that we are sticking to the guidelines is that we have a registry that helps us to evaluate what we do. Registries show us what the impact is of the treatment and can show us where and how and why and when we fail to do what the registries dictate. And what is really interesting, this becomes like almost a snowball. Because if you have good registries with good phenotype information, that can again fuel your science. Because with the phenotypical information and hopefully a biobank or a DNA depository, you can select certain category of patients and try to find out what is the genetic background, what is the metabolic differences. That generates new science, hopefully new guidelines, and can fuel again the registries, and you have really what I call a snowballing effect. Now we come to cholesterol. I know that there is a lot of skepticism still, despite our huge burden of evidence about cholesterol and cardiovascular disease. Cholesterol is not a risk factor, it's a causal factor, and that's a unique feature that isn't shared by smoking, diabetes, or hypertension. Cholesterol is needed to have atherosclerosis. And Anichkov in 1912 already dictated that without cholesterol, no atherosclerosis. Now, what we don't realize is that the impact of cholesterol doesn't start when we're 40, 50, or 60. It starts much earlier. It starts already in childhood. And that is the reason why we observe, as is depicted here in this study, so much, so early, and so serious cardiovascular problems. This is a study conducted in New Zealand, and what they've discovered is that 1 in 4 ischemic heart disease events is a fatal event. So the patients not even reach the hospital. 25%. That means they were not well protected. Maybe some of them were primary prevention, maybe some of them secondary prevention, but we were not able to prevent those second events or first events. In almost 40% of the MIs, it is a fatal event in somebody who was not even aware that he had cardiovascular disease. So primary prevention can only be properly instigated if we know that a patient is at risk. But if we fail to monitor or address that risk, this is what we observe. Very early events in patients unaware of having a cardiovascular risk. This shows you how early atherosclerosis starts. This is a 3-year-old boy, died from car accident or a shooting, I don't know. But you can see this 3-year-old boy already has the first stages of atherosclerosis. This is what is called a fatty streak. Now, did that boy smoke? Did he have diabetes? Could be, but I doubt it. Did he have hypertension? So the only thing that explains this early atherosclerosis is actually one risk factor, and that is cholesterol. This is another way, looking at a little bit farther ahead. 29-year-old female, 23-year-old male, 19-year-old male with extensive atherosclerosis in their coronary arteries, post-mortem examinations. They didn't die from cardiovascular disease, but they have already manifestations of cardiovascular disease. And I always tell my students that maybe 50% of the population dies from cardiovascular disease, but 95% of the population dies with cardiovascular disease. This is an old slide from 2001 based on the Bogalusa heart study, where they looked at many post-mortem examinations in different age categories, dying from all different kind of causes. And I just want to point out that in 17%, so 1 in 6, below the age of 20, and remember the slide I showed you from the small boy, already have manifestation of atherosclerosis. And that goes up to 37 and more than 60% over the age of 30. So unfortunately, I have to tell you here, you all have atherosclerosis. Yeah? Maybe you don't know it yet, but from now on you know it, and there is maybe something you can do about it. What is the level of a normal cholesterol? And I always give the explanation by comparing cholesterol with 2 other risk factors, and that is blood pressure and diabetes, right? If I ask you, what is a normal systolic blood pressure? everybody will say it's 120. And why is that normal? Very simple, because if it's higher, it's associated with risk, we have to treat it. If it's below, don't worry. Don't treat it, because you might fall, and that will be even more harmful. For glucose, likewise, more than 100 milligram per deciliter, maybe slight tweaks, is harmful. Below, not do anything. Now we come to cholesterol, and I ask this question almost in every continent on this planet. What is a normal cholesterol in the Pakistan population? What do you consider to be a normal cholesterol? What would be, if somebody says, yeah, but my cholesterol is normal, what kind of number has he in his mind? We're getting into the details. Let me keep it simple. Everywhere, and I'm sure you'll agree, 200. 5 millimoles, right? Now, if 5 millimoles is normal, that means if it's higher, you have cardiovascular disease. But if it's below 200, you're home free. No. Because I'm sure in your practice, 90% of your patients will have cholesterol below 200 and have atherosclerosis. So we have the wrong definition, because we use your definition. We measured in a lot of people and said, this is the P50, 2 standard deviations left and right. That's the normal distribution. And that's not the normal that we use for blood pressure and for glucose. So that is sometimes very confusing for patients, because they think, why do I have to take something that is normal to lower it? I'm not so sure if that is good, because I don't do that for my blood pressure, I don't do that for my glucose, but I do it for my cholesterol. I want to pose, and we have quite a bit of good evidence, that normal in the sense of no atherosclerosis is 60. 60 LDL. Now don't go to your practice tomorrow and then start prescribing everybody 40 milligrams of rosuvastatin and ezetimibe to get everybody below 60. Yeah, it would help, but I think that is not the proper strategy. But also, don't be afraid when people have these levels, because sometimes doctors think, yeah, maybe 60 is really low or 50 is really low, that's harmful. No, it is not harmful. It's a level where it's almost impossible to develop atherosclerosis if you have that from birth onwards. And if you have it later in life, we see quite clearly that with LDLs below 60 or 70, progression of atherosclerosis more or less stops. Maybe a little bit of regression, plaque stabilization, but no more accelerated progression. And here you see data from the PES study, which were healthy individuals. No diabetes, no hypertension, no cardiovascular disease, healthy diet, exercise, you name it, normal BMI. And then they did non-invasive imaging to look at atherosclerotic burden. And they found out in the carotids, in the femoral, and in the coronaries, they found deposit. And some patients actually had deposits in all 3 vascular beds. But there was one exception, and that were the patients with an LDL below 60. No atherosclerosis was present. Based on these normal levels, I want to introduce a concept, maybe some of you are familiar, some of you not, which is cholesterol burden. And cholesterol burden is not a single measurement, but is sort of a multiplication of your age with your average cholesterol. So if your average cholesterol is 100 and you are 50 years old, that means your burden is 5 grams. If it's 150, 50 years old, it's 7.5 grams. Now what you see on this slide is age. This is cumulative risk for myocardial infarction, and this is cumulative exposure to LDL cholesterol. And what happens is if you reach 5,000, this is when risks start to slowly increase. And if you reach roughly like 8,000, you're risk in the category of 7.5%, so that's a riskful category. That's when the events start to happen. And that is what we now sort of try to envision when we see patients and we try to reduce the risk for atherosclerosis. One person who was instrumental in conceptualizing that burden risk and also translating that into actionable things is Brian Ferencz. He's a cardiologist, epidemiologist, and also an expert in Mendelian randomization. And what he did is he looked at genetic markers, we call them SNPs, associated with slightly lower LDL. So these individuals had 15 milligrams lower LDL, and then he looked at the impact over a lifetime on cardiovascular complications. And it was reduced by 25%. So 15 milligrams, 25%. He said, what happened if we do not 15, but 40? And then he observed there was actually over 50% reduction of LDL if over a lifetime LDL cholesterol was lowered by 1 millimole. Then he did the same for blood pressure. SNPs associated with slightly lower blood pressure, 3 millimeters mercury, translating in a 17% lower risk of cardiovascular complications. If it's not 3 millimeters, but more an actionable 10 millimeters mercury, then that risk went down by almost 50% again. And in his final exercise, he combined the two. He said, what would happen if over a lifetime we had 1 millimole lower LDL, 10 millimeters lower systolic blood pressure, and that would reduce your risk by almost 80%. Now that becomes really interesting if we're not talking about an individual patient, but if we're talking about the population. If we want to curb this epidemic of cardiovascular disease, if we would start earlier, we would have really a good chance of making a good impact. Before I go on, one question I'm always asked, and I think in this context I will address it right from the start. What about triglycerides? Aren't they important as well? Shouldn't we lower triglycerides as well? Triglycerides are important, but in a different context. Because we measure triglycerides as a molecule. But the molecule itself is not the harm, it's the particle that contains these triglycerides. So we have to start thinking differently into the particles that are triglyceride rich. And the two particles I'm thinking of, or actually it's three, it's chylomicrons, it's VLDL, and it's the remnant particles. Now, particularly the remnant particles are what drives cardiovascular disease because they are small, they carry ApoB, and they can transverse the endothelium. VLDL large, chylomicrons do not transfer into the vascular space. So this shows, let me see, is this the, yeah, this is the right one. This shows you what happens if your triglycerides go up in patients with metabolic syndrome features. And what you see here is when triglycerides rise, your LDL particle number, which is here, no, sorry, this is when triglycerides rise. This is your LDL cholesterol, and you see that the LDL cholesterol goes down, but your particle number goes up. This is particles, this is cholesterol content. So in other words, you don't have maybe a lot of cholesterol, and that's what you observe in your diabetic patients. It's not that their LDL is sky high, but what is different is that they have more of the circulating particles. And with increasing triglycerides, this is what happens. So if you decrease triglycerides and you're able to reverse this, you're able to reduce risk. This is what they observed in patients without metabolic syndrome. The event rate per 1,000 years was 77,000 per year, but with metabolic syndrome, 161 in those below median small LDL particle number, and 190 in those with increased numbers of small LDL particles. And in women, those numbers were 40, 80, and almost 90. Now, what happens if you have small, dense LDL particles? They change in conformation, and you can see On the top is a normal LDL particle, and these are changed LDL particles, and they can't bind very well to the LDL receptor. They also oxidize more, they glycosylate more, and that makes them a more attractive target also for macrophages in the vascular wall. You would think that statins are predominantly used for LDL lowering, but I want to show you some old data that shows the impact of an old statin, 40 milligrams of simvastatin in the 4S study, on patients with metabolic syndrome. And this is what they observed. If you look at the overall population, this is isolated high LDL. This is lipid triad in the placebo group. This is what happened in the Simva group. So the event rate went from 85% to 41%, versus here 49 to 47. In other words, relative risk went down almost more than 50%, and in isolated LDL it was 14%, and that translated in an absolute risk per 1,000 patients treated of 17, almost 3, and overall it's 9, and a number needed to treat of 6, 36, and 11. So underlining again the importance of using statins in these type of patients. Perhaps you've heard about the PEMA fibrate, a new fibrate that has been introduced, very potent triglyceride lowering agent, and it was focusing on patients with cardiovascular disease. We had great hope that it would be very effective. What happened, it was very disappointing. These are the curves after 4 years of treatment, and you see there is no effect visible when using PEMA fibrate. Now, when we look at the changes in lipids, you can see that triglycerides were actually nicely reduced, 25, 26%. But what we didn't realize is that LDL, non-HDL, and particularly ApoB actually went up. Because if you metabolize triglyceride-rich lipoproteins more efficiently, they end up as LDL particles. So then you end up with more LDL particles and a higher risk of cardiovascular disease. Just to highlight also that early intervention in secondary prevention also carries a big bang for your buck. This is the Sweetheart Registry, famous registry in Sweden. All Swedes are in there. And this is looking at individuals that were treated for a PCI. And what they wanted to do is implement the new guidelines regarding lipid modification in patients with high cardiovascular risk. A registry, so not a randomized controlled trial, and they made 3 groups of patients. Those who started with statin plus ezetimibe within 12 weeks, and those who started with that combination within 3 months. After 12 weeks, but before 3 months, 60 months, no, 13 weeks to 60 months. And there were patients only on statin monotherapy. The majority were on statin monotherapy, and a few were on combination treatment. And this is what they observed. The curve started already to diverge very early, after a few months. Using early intervention with the statin and ezetimibe had a tremendous impact. And you can see that late ezetimibe versus only statin in all the 3 groups didn't have so much of an impact. Maybe too short, although the trial followed up for almost 3 years, but it underlines how effective a combination treatment is in patients that had a PTCA. So there are some limitations simply because it's observational, and the conclusion was that it's a very effective approach. Another challenge we face is with lower targets to reach those targets with our current available armamentarium. This was a study conducted in Romania, and what they were trying to do is to see how successful they would be using cheaper oral drugs to treat patients after an acute event with a statin and ezetimibe. And this is what they did. 264 STEMI patients after PCI, group 1, 40 milligrams of Rezuva, group 2, Rezuva 40 plus ezetimibe 10, and this is what they observed. 90% of the patients on a double therapy were able to reach a target less than 55. Here you can see in different graphic representation the changes in LDL cholesterol in milligram, and here the changes in percentages of LDL cholesterol. So I think that is very valuable news, because otherwise, what alternatives do you have? In Pakistan, not so many, but in my country, we have PCSK9 antibodies, silencing RNAs, and these are very expensive. And there's a lot of push to say, use a low-dose statin plus PCSK9 antibody that's very effective. Yeah, it's very effective, but it's very expensive. And in this way, we can do it in a very efficient way and affordable way. What about ezetimibe trials? Well, let me first show you why ezetimibe works. This is a very old phase 1 study showing that if you don't use any ezetimibe, 50% of the cholesterol passing through your intestine will be reabsorbed. And the reason is simple, because cholesterol is an expensive molecule. You want to preserve it. So half of your cholesterol is going back to the liver. That is not only dietary cholesterol. Dietary cholesterol is only a small amount. It is actually bile acid binding resins. It's actually cholesterol that's secreted. Now, if you give ezetimibe, you reduce that by 50%. So instead of 49, 22.7 is reabsorbed. But that is compensated by an increase in cholesterol synthesis. The liver notices I get less from the intestine, so I make more. Nevertheless, there is a nice reduction of 20% when you look at the change in LDL cholesterol. For statins, it's the other way around. If you reduce synthesis, your absorption actually goes up. So the holy grail is now combining the two. And what you see here is if you look at simvastatin only, and this is at production, no, this is looking at, this is ezetimibe, so production goes up. If you look at simvastatin, synthesis goes down, and if you look at the combination, there is still a nice reduction. This is looking at absorption. If you give ezetimibe, absorption goes down. Nothing happens with ezetimibe, but if you combine it, then you can see that absorption actually is reduced and LDL is reduced. So if you look at patients who have a poor response to statins, say only 10–20% reduction, many of those patients probably are more cholesterol absorption dependent, so they would have a good response by adding ezetimibe or vice versa. The IMPROVE-IT trial gave us the final evidence that it's not only lipid cosmetics, but also cardiovascular disease prevention. These were more than 18,000 patients randomized to simvastatin or a combination, followed for 2.5 years, and these were again ACS patients. What we observed is a modest reduction of risk, despite the additional 20% LDL reduction, a modest reduction in risk. But let me explain how to look at it from a different perspective. Patients who were included in IMPROVE-IT were more or less in this category. They already had a very low baseline LDL, right? If you reduce LDL 23% and your baseline is low, the amount of LDL you reduce is also very little. And that means also, if you're already at 70 milligrams, your risk is also lower. So the impact in that latter part is very low. But if you look at those who were at high risk because of high cholesterol, we can see there is actually a very sufficient way of reducing cholesterol in milligram and reducing risk. Another way to look at higher risk patients. So these were individuals in the improvement prior CABG, and here the risk was reduced by almost 8.8% and a number needed to treat of 11 compared to the ones with no CABG. Last, I think it's also interesting to see the impact of statin intensity and ezetimibe on changes in glycemia. And what you can see here is the impact of no statin, moderate and high intensity statin when your baseline glucose is less than 100 to 125, and this was the complete study population. And you can see there is indeed, in the ones with high glucose, an increase in the onset of new onset diabetes. Now, when we look at the individuals that were in the same categories, but now there's an extra statin plus ezetimibe, there is not such a big impact on this new onset diabetes. Realize it's still there, because I always say it's not statins that cause diabetes, it's the diabetic risk factors, obesity, insulin resistance, that cause diabetes. But you can see that it's in that combination an interesting way also to address glycemic control. Very short and brief, the guidelines, there's many. We have more than 70 lipid management guidelines. I'll just show you the European guidelines, the 4 risk categories that we're able to treat, and this really elegant slide showing you which risk category should be treated to which goal. I think everybody is familiar with this slide. What I like about the European guidelines is the 3-step approach. Step 1 is lifestyle, and that's not for patients, that's for everybody. And step 2 is that you look at achievable good targets of a blood pressure below 140 and an LDL, in this case, less than 1.8, 70 milligram per deciliter, and more than 50% reduction. In step 2, you can go even further, and now suddenly systolic blood pressure has to be below 130, and LDL has now to be below 1.4 or 55 milligram per deciliter. So this approach guarantees that even in developing economies, step 1 can always be achieved. And even with the lipids, step 2 is not unrealistic if you combine with statin ezetimibe. Ezetimibe is now high evidence as a combination to a statin, and as I showed you before in the Sweetheart study, it really makes sense in very high-risk patients to initiate it very, very early. To conclude, I think it's very safe to say we need to still keep focusing on cardiovascular risk prevention. It is not a done deal. It's actually still expanding, and simply only focusing at the end stages of the disease and hoping for a magic pill that will obliterate cardiovascular complications is an illusion. It's not possible. We have to start thinking about earlier. And I think that based on new algorithms, we are able to sort of customize a sweet spot when it would be most optimal to start with lipid lowering and maybe even with blood pressure lowering therapy. And my prediction will be it's around the age of 30 years, and in some individuals even younger. Normal cholesterol, remember, is less than 70. Less than 70. It's not that everybody needs to have it, but this is the safe level when you don't want to have no progression of atherosclerosis. So aim for that. Even in individuals where the risk is maybe not so high, I'm not so in favor of having these differentiated targets. I think going for a low target really pays off. We have to start earlier, as I already said. Ezetimibe, attractive statin add-on, single pill combinations make compliance and adherence much easier. And we do need this stepwise approach where we focus on the baseline risk and then continue with the more advanced risk, where also new therapies for inflammation, maybe omega fatty 3 acids, can be implemented in those with a high risk of recurrence. This is my last slide, and that's the major challenge. I've discussed it with many people already. We know everything, and if you're smart enough, you can understand everything, but the problem is to change how you do things. Yeah? These guys are laboring with square wheels. And this smart guy came up with a brilliant invention, round wheels. What do? Forget it. I don't have time. We continue like we did, as we always did. And that is a little bit what we're facing sometimes when we try to implement evidence-based management of patients on cholesterol management. That was my last slide. I hope I didn't go over time too much and we still have some time for questions.
Because of time constraints, we are not taking question and answers right now. Professor Peter is here, we can discuss afterwards. So our panelists, please give a brief comment regarding the talk. It was really an amazing interactive session, no doubt, sir. Professor Qazi Abdul Sabur.
Thank you very much. Very excellent talk, as usual, by Dr. Peter. And my comment is on that, whatever we are doing our best in secondary prevention. But we are, you see, doing very less in the primary prevention. Actually, we have these target in more and more in the primary prevention. And my small question to you is, what is the, role of bempedoic acid with the addition of both these two drugs?
So, if I understood well, because there's a lot of echo, you're wondering what the role of bempedoic acid is in the lipid management. Is that a good summary of your question? Yes? So, for those who are not familiar with the new lipid management drugs, bempedoic acid is a new drug that also inhibits cholesterol synthesis, but slightly early in the cascade. And it shows roughly a 20 to 25% LDL reduction. You can use it as a monotherapy, although it's not very strong, it's not very potent. Or what you often see is that you can combine it. So when do you combine it? You can combine it in patients who have severe statin side effects. So they're really unable to use a statin, and then you can combine ezetimibe plus bempedoic acid and maybe a very small dose of statins every other or every 2 days. Another category are patients with familial hypercholesterolemia, where you are so high that you want to throw everything at them to lower their LDL cholesterol, and then bempedoic is, of course, a very good drug. And in the last case, again, similar as FH, in secondary prevention, where individuals are unable to reach the target even with a statin and ezetimibe, then bempedoic acid can be added on top of that. I think those are basically the three categories. Now, there's one unique feature of bempedoic acid, and that's it's administered as a prodrug. So it has to be activated. The activation is only possible in the liver. So the theoretical thought behind that is that it won't be activated in the muscles. And that should reduce muscle symptoms. That should not at least exacerbate muscle symptoms. And that is why this could be an additional way of treating patients with severe muscle problems.
Thank you very much, sir. Thank you. Professor Bilal Zakaria, please, only 30 seconds comments, please.
Wonderful talk. I just wanted to actually highlight the fact that with the data coming from Improve It, the combination of simvastatin with ezetimibe, which in our environment is going to be much cheaper than using a third generation statin with ezetimibe, Improve It has shown a remarkably improved lipid results and prognostic improvement in patients it was given in the combination. So what advantages do we have if we use a third generation statin with ezetimibe as compared to simvastatin and ezetimibe, which was originally sort of introduced about 15-20 years ago?
Yeah. So the question is, what's the advantage from using new high-intensity statins as rosuvastatin and atorvastatin versus what we used in the Improve It, which was simvastatin? I'm not sure how popular simvastatin is, but in Holland we hardly use simvastatin anymore. And one of the reasons is that it's not as potent as atorvastatin or rosuvastatin. And the second reason is that there is a propensity for more muscle-related side effects. We did a trial with 80 milligrams of simvastatin, and we observed quite a bit of rhabdomyolysis. So that's another reason why we sort of hold back with simvastatin and would prefer rosuvastatin or atorvastatin. Yes?
Professor Noman Nasir.
As always, an excellent talk.
Thank you.
You, on your last slide, have mentioned the combination rosuvastatin ezetimibe. I know it's a event sponsored by that combo. Recently, I've switched to moving, if I'm using high-intensity therapy, I generally try atorvastatin first. If they don't tolerate it and you have to try different salt, then I shift to rosuvastatin because of the recent data from one trial, because there's slightly higher incidence of hyperglycemia, cataract, being on rosuvastatin versus atorvastatin. Do you take that into factor? You really don't care about that? I've been doing that. I know it's a soft thing.
Well, you know, there are differences between rosuvastatin and atorvastatin. If you look at the really distinct difference is that you cannot use 40 milligrams of rosuvastatin, at least in an East Asian population. It has not been properly tested in a South Asian population, but in countries like Japan, Taiwan, China, there is no rosuvastatin 40 milligram. And that is related to a higher risk of renal problems and muscle-related problems. But with 20 milligram, I think it is safe drug to use. And in combination with 20 milligram plus 10 milligrams of ezetimibe, you can still reach that 60-65% reduction. Yes.
And we have a lot of population with hypertriglyceridemia despite after statin therapy and stuff. And you know, the guidelines are much more relaxed about how you approach hypertriglyceridemia.
Yeah.
And with the fibrates data being negative, you know, you don't want to use that drug either. You're not getting any outcomes from that. How strongly do you push for Vasepa, EPA, DHA, EPA salts, you know, so Vaza, I mean, there is data supporting them. It's not available in Pakistan right now, but you know, how strongly do you push for that in these populations with hypertriglyceridemia and with established cardiovascular disease?
Yeah, so the question is how well can we treat patients with hypertriglyceridemia? My first remark is that statins are very powerful to reduce triglyceride. If you use high dose, high intensity, you can reduce triglycerides by 40%.
Thank you very much, sir. Because of time constraints, we are concluding our session right now.
Okay.
We have to start another one. We will discuss inshallah later on.
Okay.
Thank you very much.
Thank you for the question.